Welcome to the 12th and final module of the series, Learning from Diagnostic Errors. To recap from the prior module, standard of care is defined as what a reasonable and competent physician would do in the same or a similar situation. Knowing the outcome or results of an imaging study before reviewing the study significantly influences their interpretation and the ability to identify subtle findings. This is known as hindsight bias. The most frequent diagnosis-related cancer allegations for radiologists are breast, lung, kidney, colorectal, and pancreas. Poorly written reports are a major contributing factor to claims alleging diagnostic failure against radiology practitioners, and there are strategies you can employ to reduce your risk of diagnostic error and subsequent malpractice. The goal of this module is for learners to understand how to develop and implement a system to learn from diagnostic errors. The learning objectives are to explain approaches to identify cases with diagnostic errors, describe the importance of analyzing errors for contributing factors, and discuss interventions that address contributing factors and can reduce diagnostic errors. I want to start with a simple system that you can use to reduce diagnostic errors. There are four main components. The first component is identifying errors with or without clinical impact. It doesn't matter if there's clinical impact because we can learn as much from a near miss as we can from an event that harms a patient. Once we identify errors, we need to analyze those errors to identify systematic causes of error, bias as a contributor to other errors, and other contributing factors. When we understand the contributing factors to errors, then we can develop educational initiatives and system improvements to address those contributing factors. And underlying these processes is having a culture that supports reporting and learning from diagnostic errors. Remember that the goal is not to identify low performers. The goal is to identify best practices that we can share with everyone and shifts everyone average performance to the right so that we all do better. There are multiple approaches you can use to identify cases with diagnostic error. These include non-random peer review, prospective double reading, multidisciplinary conferences, outside interpretations, resident and fellow overreads, retrospective chart review, radiology pathology, and radiology surgery correlation. The reason why I include outside interpretations and resident fellow overreads is because when you've seen a lot of errors, you realize that we all miss the same things for the same reasons. In the case in the upper right, this is a missed neuroendocrine tumor that was identified during routine clinical work on a subsequent exam done for other reasons. The image on the bottom left shows an incidental pulmonary embolism that's missed on an outside study. And the image on the bottom right shows a cervical cancer that was called a fibroid and was eventually diagnosed during surgery that was discussed at a gyn-oncology tumor board. We can learn from all of these cases. The reason I don't talk about random peer review and rad peer is because this is not an effective approach to identify and learn from errors. There are a number of limitations that limit the usefulness of rad peer. These include evidence of submission bias resulting in significant underreporting of serious discrepancies, poor inter-rater reliability, reports not being blinded and subject to hindsight bias, random sampling requires a significant number of cases to be reviewed, and the 5% review recommendation is not evidence-based and may not allow valid statistical comparisons. The most important limitation, though, is that it results in a discrepancy rate for benchmarking and comparison, which limits its usefulness for performance and quality improvement. It can't serve both purposes at the same time. I think Upton Sinclair said it best when he said, "It is difficult to get a man to report something when his livelihood depends on his not reporting it." Learning from diagnostic errors requires understanding the factors that contributed to the error so that interventions can be designed to mitigate or eliminate these contributing factors. One very effective method of uncovering contributing factors is root cause analysis, a non-punitive structured process that consists of three fundamental components: consideration and identification of factors more directly associated with the error, analysis and prioritization of these factors to develop effective strategies to prevent the error from recurring, and introduction, management, and dissemination of effective countermeasures that are shown to have a beneficial effect. Here's an example of how root cause analysis should work. The resident interpreted the CT on the left as no acute intracranial abnormality. A prior CT from a year ago is shown on the right for comparison. This is a 30-year-old patient who was found down in her bathtub after an argument with her boyfriend. She deteriorated over the 6 hours after the initial CT on the left, had a repeat CT which was then interpreted as diffuse subarachnoid hemorrhage. So this case was reviewed, and when we analyze it using root cause analysis, we realize that the resident was interpreting studies from Hospital 1, where new studies are loaded on the right. He was called from an ER physician from Hospital 2, so he rolled across the room, loaded up the study in packs, and didn't realize that new studies loaded on the left instead of the right. He looked at the study on the right, thinking it was the new study, and dictated it as no acute intracranial abnormality. So here, you can see that the intervention is not resident education or remediation or 24/7 attending reads. It's to standardize hanging protocols across the hospitals. This could have happened to any of us. Once you identify errors, you can analyze them for contributing factors. One way to do this is to use a fishbone diagram. You have multiple categories, such as people, environment, equipment, policies and procedures, processes, and pathology. And under each category, you have multiple types of contributing factors. So if we think about that recent case of missed subarachnoid hemorrhage, the contributing factors are work pressures. It was a busy overnight call shift for the resident. Interruptions, the ER physician called for a wet read. And PACS factors. There were different hanging protocols at both institutions. Now that we know the contributing factors, we can think about systematic interventions that would be effective at reducing or eliminating this type of error. Now I'm going to spend a little bit of time talking about interventions that are effective at reducing error. When I was a resident at Penn, we did a study looking at major discrepancy rates. We observed a statistically significant increase in major discrepancies for residents during the last 2 hours of a 12-hour overnight call shift. That's shown in the bars in light gray. We shortened the call shift by 2 hours, and this resulted in a significant decrease in major discrepancies for CT and ultrasound, with a peak no longer observed during the last 2 hours. The overall improvement in major discrepancies was 30 to 40%. This is an effective intervention to reduce errors. I also want to talk about the impact of missed case conferences. In the same cohort of residents, we identified 31 common and important musculoskeletal injuries missed or misinterpreted in the ER setting by residents over a 1-year period. We then took those misses and developed 4 simple, focused missed case conferences to educate the residents. And then we looked at these type of misses over the following 12 months. We observed a 66% decrease in the errors related to these types of entities over the following 12 months. Moreover, what we saw was even though fellows had a better major discrepancy rate than residents, the major exception was plain films done in the ER setting, where residents had almost half of the major discrepancy rate of fellows. When you look at what the fellows were missing, they were missing the types of injuries that we were teaching the residents about. Educational interventions such as this can be very effective. When I was at the University of Virginia, we identified a series of missed cases that helped us develop a systematic intervention. There were subtle pelvic fractures missed on 5mm soft tissue reconstructions, subtle osseous metastases missed, and incidental pulmonary emboli missed. The contributing factor was that they were difficult to see on the 5mm reconstructions. So we started doing 1.25mm reconstructions for all of our CT abdomen pelvis studies. The pelvic fractures then became more conspicuous, as did the osseous metastases, the pulmonary emboli, and subtle liver metastases. Another intervention that I've talked about in a prior module is structured reports with fields dedicated to blind spots. This is a patient who had difficulty extubating over about 10 days. He had had multiple head CTs and chest x-rays, which did not identify the aspirated dental plate until a radiologist finally looked at the scout view for a head CT and determined the cause. So the intervention here is adding a dedicated field for people to look at the scout view. We can also do it for the scout and coronal T2 images, and this is the example I showed before of a synchronous sigmoid cancer that was missed on a rectal cancer staging study. The last example is for missed incidental lower lobe pulmonary emboli, where the intervention is to have a dedicated field for the lower lobe pulmonary arteries. The idea for this online curriculum came from writing a manuscript about diagnostic errors and thinking about both contributing factors and interventions. There are very few educational resources available to radiologists and trainees that help them understand why diagnostic errors occur and what we can do to avoid them. Diagnostic errors are predictable and preventable, similar to many of the medical errors we come across. The material in this curriculum is a first step towards providing high-quality content about diagnostic errors in radiology. The last component of having a system to learn from errors is culture. We need to have a culture that supports reporting and learning from diagnostic errors. The kind of culture you want transitions from the old way of thinking to the new way of thinking. This is characterized by going from thinking that people are the cause of errors to systems are the cause of errors. We go from a culture of silence to a culture of reporting. We go from asking who made the error to why was the error made and what can we do differently. And we go from remediating and training people to redesigning care delivery systems. To summarize, reducing diagnostic errors begins with identifying cases of error, regardless of clinical impact. Errors should be analyzed for contributing factors. It is critical to know the contributing factors for any interventions to be effective. We need to develop both educational initiatives and systematic improvements from these cases of error. And we need to create a non-punitive culture of quality by emphasizing that systems are the causes of error. We should report errors to learn from them, and we need to redesign systems to reduce errors. Congratulations, you have now finished this module on learning from diagnostic errors. Please take a minute to give us feedback.